Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
So here's my presentation I have for you guys. So you want to do cardiology. So what I'm hoping to do here today is to give you a little bit of insight on how you get to become a cardiologist, what's the training involved, what's the various avenues you can take after you go into cardiology, because it's cardiology, but now in this day and age, we're really compartmentalized and subspecialized into numerous different facets of cardiology, which makes it so interesting and exciting, and there may be something for everybody there. So we'll talk a little bit about that, the training and the time of training involved, and a little bit of insight of what my job is like. And then we're going to go over sort of a typical type of bread and butter case for someone in interventional cardiology like myself. Okay. So becoming a cardiologist. Well, first thing you got to know, there is a lot of schooling and training involved, right? And there's some fields that require less training. Interventional cardiology is pretty much the same as becoming a neurosurgeon, and there's a lot of training. So you obviously got your 4 years of undergraduate, you got your 4 years of medical school. There are 7-year combined program options, which I had considered at one point. In retrospect, I wish I had considered it strongly because, like I told you earlier, every year counts once you hit your 30s and 40s. Training, so 3 years of internal medicine residency, 3 years of cardiology fellowship. For the most part, there are some programs that have a sort of combined internal medicine fast track cardiology where they do it in 5 years. There's not a lot, but there's some. There's also some on the opposite spectrum cardiology programs that have 3 years plus 1 or 2 research years if you really want to go the intense research academic route. And so, it really depends what you're looking for. After general cardiology training, then there's further subspecialty training that can happen, which is 1 to 2, maybe even 3 years, depending on what you're looking for and what type of specific subspecialty you're interested in. And then there's always the optional research years that you can do. Some people tack on actually additional years in between residency and cardiology. For example, sometimes people don't match into cardiology, so they do some other ancillary cardiovascular imaging or echo or some kind of training programs you can do before fellowship, actually. So there are options for that. So there are a lot of different ways to get to it. And of course, other extra years. A lot of people do a chief residency year that acts on the extra year. Doing a chief resident year definitely improves your application, your chances, particularly if you're looking to stay at your own particular program to carry on. And again, we talked about the research years, and I took a research year between college and med school. Folks do that, and that's something to discuss with your college advisor if they feel your application could warrant it. Definitely one of the most competitive specialties. We talked a little bit about this before. A lot of things that do matter. Obviously, medical school and your scores in medical school are very important. The residency program you go to is important. Your UCMLE scores, although this day and age now we have a pass-fail for UCMLE step 1. So things are changing a little bit there. Research experience and letter of recs, perhaps even more important now with the pass-fail of USMLE. So, and this is always a moving target. And this is just a small snapshot. There's a ton of other things and ways to sort of help improve your chances of getting into a cardiology fellowship. So talk a little bit about cardiology subspecialties and the training involved. So we talked a little about the cardiology fellowship, right? So that's 3 years in general, okay? A lot of people, I don't know the exact numbers, how many people actually go into subspecialty. It definitely varies by year to year. Interventional cardiology, clearly one of the more popular and still probably the most common subspecialty in cardiology that people choose. In general, bread and butter interventional cardiology is 1 year. And sometimes extra training for an additional 1 year if you want to do more advanced training. So, when I was there was just interventional cardiology. Now they're having more accredited programs for additional training for structural interventions, and she'll talk a little about that later, and peripheral vascular procedures as well. So there are various models of additional training that can occur. Then there's the second most popular subspecialty is electrophysiology, right? So, interventionals, we're the plumbers of the heart. The electricians are obviously, the electrophysiologists rather are the electricians of the heart. That is now, used to be 1 or 2 years. Now it's pretty much around the board 2 years. So you're looking at 2 years of training if you want to do electrophysiology. What's becoming more and more popular also these days is advanced heart failure and transplant, right? So those are, and we'll talk a little bit about what they do, and most of those programs are also 1 year. And then advanced imaging specialists. With the advent of more usage of cardiac MRI, we're seeing a lot more of these trainings pop up as well. So that's also an additional year for cardio advanced imaging. Okay, and then there's other niche specialties. Some of these have, not all of them have accredited training programs, but you can find some non-accredited ones for more niched training, and that can include anything from adult congenital heart disease, cardio-critical care, which is, a lot of people have been combining cardiology fellowship with a critical care fellowship, and there's actually like additional training after cardiology to do critical care. Cardio oncology is also becoming, buzzworthy these days. Sports cardiology, this is just to name a few. And there's even subspecialty things that people just programs make up on their own and train people in. So you can really sometimes find a really innovative and, types of niches of subspecialties if you look around for it. So let's talk a little bit about what some of these most common versions of cardiology are. So non-invasive cardiology or general cardiology, right? So this is sort of the bread and butter cardiology. You finish your 3 years of fellowship, and this is basically what you'll come out with. So again, there's a lot of variations of this, and I'm just giving you a little snapshot of how you can model it. Of course, there's the office-based cardiology, right? So this is basically, and some cardiologists purely do office-based, right? There are programs like that. They don't even go into the hospital, and you may be just an office cardiologist. Maybe you're seeing patients in the office, and people see anywhere between 15 up to 40 patients a day in the office. These are new patient consults, follow-up patients, and you're going to be managing these patients with medications, disease states from heart failure, coronary disease, angina, things like that, atrial fibrillation. And sometimes you're going to be referring these patients to more specialized care if they need procedures, and ordering various testing, stress tests, echoes, and these kind of things. So you're a diagnostician, and you're treating them with various different medications in the office setting. Then there's the inpatient side of it. Obviously, inpatient side is patients who are a little bit sicker. These are patients who are admitted to the hospital. And this is patients you're going to be seeing in a consultative fashion, right? So a patient is admitted to the medicine floor, and you're being called in as a consult for someone with chest pain or an arrhythmia or something, that you're going to help manage that patient in the inpatient floor as a consultant. Then there's the CCU side of it, the cardiac critical care unit, right? So different hospitals have different setups for how all these things are done, but the critical care side is basically someone who's sick enough to be in the CCU. Generally, there's 2 ways that it happens. There's sometimes one doc who takes care of the entire CCU unit, and there's some models where different cardiologists will take care of their own patients in the CCU. So that's a little bit sicker patients, and varies from patients who have just undergone a stent for an urgent heart attack to patients in severe cardiogenic shock, severe heart failure, and things like that. So that's kind of, to me, the inpatient side. The exciting part is the CCU, because you really get to take care of the really sick patients, and you can really, you learn a lot, and you get to do a lot on the inpatient side, especially with all the devices that we have these days and mechanical support devices. We can really do some amazing things in the CCU, and even these are taking care of patients who are not even interventionalists, just general cardiologists. So other things non-invasives do, reading studies, right? So this is also a lot of the bread and butter. This is what brings in the revenue for a lot of practices. And this is, the heart of the testing of non-invasive testing of cardiology, okay? So we're talking about things like echocardiograms, which is basically ultrasounds of the heart, various types of stress tests, nuclear stress tests, and other types of nuclear scans of the heart. They're different, not just a nuclear stress test, we're looking for coronary artery disease and blockages, but they're different type of nuclear stress test and nuclear scans that we do in cardiology looking for other things. Vascular studies, right? There is a lot of, we're cardiovascular specialists, so there is a lot of overlap in what we do as cardiologists with vascular disease. Like myself, for example, I do a lot of peripheral vascular work where we overlap a lot with vascular surgeons. That often leads to a lot of turf wars, but there's also a lot of collaboration that occurs there. So, we take care of patients with carotid disease, peripheral vascular disease, subclavian disease, venous disease, and we do all. And for example, in our office, we do ultrasounds for all those disease states, and we read those studies. Holter monitoring and loop recording. This is for patients with arrhythmias and palpitations and those sorts of things. So, we're evaluating somebody with palpitations or in any particular arrhythmias. We do all kinds of heart monitoring. Now that whole realm is progressed a lot, with the wearables, the Apple Watches, and the advancement we have in the tech with wearable devices. I think that's an area that you're going to see a lot more buzz about. And with these algorithms and these machine learning AI, there's really fascinating stuff going on with wearable devices and EKG monitoring. So really cool stuff coming out in the future pipeline, I think, with AI is marrying with cardiac monitoring devices. So, this is a lot of people, use their cardiology experience to go into, entrepreneurial stuff and innovation. So again, a lot of things that you can do with some of these things beyond just clinical medicine. Other advanced studies, also PET, not everybody does this. This is getting a little bit more niche, but PET scans, CT scans, and cardiac MRIs. Again, these are imaging studies that even if you have not done an advanced fellowship, some people still do PET and CTs, MRIs is basically most of the time more advanced imaging folks. And most practices are a combination, right? I talked a little bit about my role. I do a little bit of interventional. I do a lot of non-invasive. I do most of these things aside from, these advanced studies in my office setting. So having that balance is kind of nice. So that's non-invasive cardiology. Electrophysiology. So now we're moving on to the electricians, right? So these are the heart rhythm specialists. So electrophysiology deals basically niched with any kind of heart rhythm disorders. And this can, the most common thing is, for example, atrial fibrillation. That's, getting a huge, we're getting more and more patients, population's aging, there's a ton of atrial fibrillation out there. So they take care of those patients quite readily. Other types of arrhythmias as well, such as SVT or supraventricular tachycardia, WPW, ventricular tachycardia. There's a lot of arrhythmias out there that require treatment. And this can be from things such as medical therapy. There's a lot of advanced antiarrhythmics. I'm sure in med school, we've learned these, and those are like always torture to figure out what's class is this antiarrhythmic, what's the channel that it blocks. And, electrophysiologists are the experts in that. And of course, with all these cool advancements in catheter-based therapies, it's really amazing what they can do. And they're basically putting catheters through various parts of the heart. They're mapping the signals of the heart, kind of like you see in the top right here. This is an example of an AFib ablation where they've mapped all the impulses of the heart and they put burn marks to zap out the arrhythmia by creating these lines. You're really basically just charring lines into the atrium. And by doing things like that, they can eliminate arrhythmias. All right. And this is showing just a snapshot on the bottom right of the type of intracardiac arrhythmia. This is their version of an EKG. This may look a little foreign to us, but they're seeing things in kind of like matrix code when they're in there. So other things that they do are device implants, right? So defibrillators and pacemakers. That's also a lot of the bread and butter of electrophysiologists. So patients who have slow heart rates or heart block, they're putting in various types of pacemakers, and patients who have cardiac arrest, ventricular tachycardia, or have severe heart failure and cardiomyopathies, they put in preventative devices or ICDs or defibrillators, right? These defibrillators are implanted into the heart like a pacemaker, and they are designed to protect you against rapid heart rhythms and cardiac arrest. And once these devices go in, the electrophysiologists are responsible for tweaking these. There's a lot of like programming and tinkering, and really they have to put on their sort of the engineer hat to kind of figure out small nuances and how these things are programmed, and a lot of computer stuff goes into it too. So it's not just putting the device in, it's really following these devices, problem solving. It's really fun stuff when you get to learn about it. And if you like that kind of thing, this could be good for you. Other things, we talked about catheter ablations, Watchman procedures. This is an overlap where you see with electrophysiology, interventional cardiology. Watchman procedures are where we're putting in a occlusion of left atrial appendage, another way to manage atrial fibrillation to reduce your stroke risk. So this is just a little snapshot of what electrophysiologists do. Cardiovascular imaging specialist. So this is, I talked about before, you're basically becoming a cardiac radiologist, right? So you're going to be specialized in the bread and butter, which is nuclear cardiology, echocardiography, TEE, which is transesophageal echocardiography, right? Where we're putting the ultrasound probe down the esophagus to get better visualization of the heart, and various structures and valve disease, and CTs, so, this is just a little snapshot. This is an example of a coronary CTA. On the right, upper right, you have an example of what a 3D TEE looks like. A TEE guided structural procedures are huge. So we have cardiovascular imaging specialists who are basically trained in invasive TEE, meaning when we're doing things like MitraClips and Watchman procedures, we really rely on our echocardiographers to guide us. So, you're not just an imager, you're working directly with the interventionalist, and we're leaning on them to tell us, are we in the right spot? Where should we go? So, really it's become an amazing collaboration when we're treating valvular heart disease and Watchman procedures. So there's really cool stuff in the imaging space as well. And you get to scrub into these cath lab procedures, and you're just, if not more important than some of them. Advanced heart failure, we talked a little about this before as well. So advanced heart failure doctors are medical doctors that take care of advanced heart failure and transplant patients, right? So it's their job to evaluate patients and figure out, okay, is this patient a candidate for something like a left ventricular assist device, or maybe even a transplant, okay? And they're the ones who are going to be managing those patients post-operatively. So they work really close with the transplant surgeons. They're very good at taking care of very advanced, sick heart failure and cardiomyopathy patients, right? So we lean on this team of docs to help us with the very sick advanced patients. They're also, they don't put in surgical LVADs or transplants, and they don't put in things like mechanical support devices such as Impella and ECMO devices, which are basically mechanical support devices that us as interventionalists put in to support the heart when the heart is severely failing, whether it's a chronic problem or acute heart attack. And these doctors come in and help us manage those devices, and they help us, segue the patient from getting out of the woods and into a potential transplant situation. So we're sort of the plumbers. We go, we stabilize them. They're really the smart guys who kind of help tweak them and get them out of the woods. So again, a real collaboration with the advanced heart failure specialists and interventionalists in the acutely sick patients, and they focus also on the very chronically ill patients. So a very growing and important field. And we're seeing more and more of these folks out there. And some of these docs also do some procedures such as cardiac biopsies and right heart catheterizations. There are some procedures involved as well. But this is also, again, a very popular subspecialty these days. Then, of course, the best interventional cardiology. And, as a lot of you guys know, we're basically talking about catheter-based procedures. We're ways we can treat the heart without open heart surgery, which started off in the old days with just coronary angiograms and coronary stenting. And now it's really blown up, and we can treat all sorts of cardiac issues, from valve disease to congenital heart disease to coronary disease, with very advanced cardiovascular procedures. These are basically fluoroscopy guided procedures, right? So we got patients on the cath lab table with a live x-ray, and you can see an example of a little angiogram here where we're injecting dye into the arteries, and with wires, balloons, and stents, we're using live fluoroscopy to put wires and equipment down the arteries and treat blockages and other things such as that. And by that same technology, we're able to treat various valve diseases, mitral valve disease, aortic valve disease, pulmonic, and tricuspid. We basically have technology to treat all 4 valves now, further, giving more options for our patients that otherwise would not have options. Coronary intervention is definitely the bread and butter. So when you go into interventional cardiology, the first thing you're going to learn is coronary disease. That's, again, what all interventional cardiologists know how to do. And from there, if you want to further subspecialize, there are different routes that you can go. And there are all kinds of fun tools, even just in the coronary realm. We talked about stents and balloons. Specialty balloons. Actually, recently, just yesterday, was approved a coronary lithotripsy balloon, which is basically a balloon we're putting in the coronary artery for very calcified lesions, and it's emitting lithotripsy, kind of like you treat with kidney stones. That just got approved in the US yesterday, so we're excited to start to use that. Just an example of all the awesome technology that's really coming out there. And again, less and less bypass surgeries occurring because we have so many fun tools that we can treat patients with these days, and it's going to continue to advance. So then I put this on a different slide because it's basically becoming like its own subspecialty now, interventional structural cardiology. So where interventional cardiology is the bread and butter of coronary, structural is becoming its own sort of subspecialty. And this is basically treating valve disease, all right, congenital heart disease, and other things such as, other things such as the Watchman device for left atrial appendage occlusion. The biggest thing in structural heart disease, of course, is TAVR, or transcatheter aortic valve replacements. This was probably one of the biggest innovations in medicine in the past 10 years, if not just cardiology, where we have technology to treat the aortic valve by percutaneously by a tube up the groin, up and replacing the heart valve without any incisions. Patients can go home, the next day, if not the same day, with these procedures, and it's really revolutionized how we treat heart valve disease. Mitral disease, again, on the top left, this is a picture of a mitral clip. This is a percutaneous clip that we place on mitral valve for patients who have mitral valve regurgitation. Obviously, the only way to treat that previously was open heart surgery to repair the valve. Now we can put these little clips in there to clip the valve to prevent the leakage, and this is done by going up to the right side of the heart, piercing across the septum to the left side of the heart to access the mitral valve. And here is an example of the Watchman device. This is what I was stuck doing all day today. This is when we're putting a little plug into the left atrial appendage. This is for patients with atrial fibrillation who need to be on blood thinners to reduce the risk of stroke. And that's because this little appendage here forms blood clots. And, of course, if we're using blood thinners just to kind of treat this one little area in the heart, people bleed all the time. So now we have these little devices where we can, again, go up the right side of the heart, we pierce across the septum, and we plug up that little spot there, occluding it and separating it from the body. Therefore, the patient's going to come off blood thinners because if you form clots in here, it can no longer enter the heart. So again, really cool stuff that we get to do. Peripheral vascular interventions. Also, this is something that we do. This is in our realm. So just like you have blockages in the heart, you can get blockages in the arteries of the legs. Again, this is something you see a lot in smokers and diabetes. Leg blockages in the iliac arteries, the femoral arteries, the tibular arteries, also subclavian arteries and the carotid arteries. All these arteries can have blockages. All these can be treated with percutaneous measures and stents in the right scenario. Obviously, there's still a role for surgery here. But, we have similar skills. I mean, if we can put in stents in a moving heart, when putting a stent in a larger artery in the limb that's not moving, not that difficult. So very similar skill sets. It's not that difficult, but you know what I mean. But it really similar skill sets, and again, involves some additional training. Again, this is some cardiologists really specialize specifically in this particular niche. So a lot of avenues that you can go. And lately, what we're seeing a lot of is invasive treatment of DVT and PE. In the past, the only things to treat DVTs and submassive and massive PEs was either anticoagulation or sometimes thrombolytics. Now we can put catheters in there, and we can suck out clots from the lung arteries. We can infuse thrombolytics in there, and we find that this seems to be a very good procedure for a subset of patients. And even DVTs, particularly young patients with big leg clots in the old days, and even these days, a lot of people are just treating these with anticoagulation, but we can actually go in there, remove these clots, and in the right patients, it can really improve quality of life. And again, these procedures are done by interventional radiologists, vascular surgeons in some cases, and cardiologists in a lot of cases. So again, a lot of overlap, like we talked about before, but this is just a little bit of a snapshot of some of the things beyond coronaries that we get to do in the world of interventional cardiology. And like I said, there's some people who focus literally on just the mitral and the aortic valve. Some people literally just do vascular. Some people focus on venous. So you can really find what you love and what you like the most, or you can do a little bit of this and that, So a lot of good options out there. A little bit about the types of jobs out there. Again, there's a lot of different types of jobs of cardiology. Again, just to break it down briefly, academic jobs. Academic jobs, when we're talking about working, at a large hospital, under a teaching institution, generally these are more specialized and compartmentalized, meaning that you'll have the non-invasive general cardiology docs doing their thing. The interventional doctors would specifically just focus on intervention procedures. Then you'll have, one guy who's doing aortic valve procedures, one guy maybe doing the mitral valve procedures. So everyone has their specific niche, and maybe they have research interest in that specific niche. So they're becoming really sub-specialized, thought leaders, experts in that particular niche, right? There's also both clinical care involved in that and research involved in that, and sometimes as well as education. So those are sort of, brief nutshell what the academic job realm is. Then there's the clinical jobs where, this can be private practice. This can be a hospital employee for a private hospital. They often do a mix of things, right? Where, they're focusing mostly on taking care of the patients. They're not doing much research or education necessarily, but sometimes they do. And they're, they may be doing a little bit of everything. Okay. Then there's hybrid models. Like I'm more of a hybrid model. I'm a private practice employee, but I have I'm an assistant professor. I have an academic title. I work at a teaching hospital. I do a lot of teaching. I do a little bit of research. So I like to do a little bit of a balance there. I didn't really like wanting to do 20% of research, but I loved education. So I want to focus on doing procedures, clinical care, and educating students, fellows, and that sort of thing. So that's the niche that I created for myself. And there's a lot of ways to go about that depending on what you like to do, right? So again, I talked a little about this already, about what I do. Again, hybrid model between academic and private practice. I do interventional and structural procedures, which is what I love to do, as well as clinical cardiology. I never want to give up my clinic. My patients would kill me. I love my long-term patients. I love seeing my patients after I do a procedure, right? There's some interventionalists who, they'll urgent patient comes in, they'll treat a patient who's having a STEMI or an acute heart attack, save their life, they'll never see him again. I like to see these patients in the clinic. It's so satisfying to see someone who's on the table half dead, and I see them 2 years later and they're looking great, and I get to see them every 6 months and really build that bond. So for me, that satisfaction and that, was more rewarding to me than just doing the procedures and working on our research, for example. And, I split my time between office and procedures, like we talked about, and mixed in is other things, administrative work, meetings, a lot of teaching sessions. And, there's barely any time for meetings and lectures. And that's usually early morning, late morning, and evening sessions. And like we're doing here today. So, you got to find time to get things in. And weekends always works too. So, but remember, cardiology is not, every cardiology job is going to have weekend work. This ain't dermatology and allergy. So, people get sick on the weekends. So, this is one of those positions where you're going to have to work weekends. But, it can depends on the situation you're in. You could be working every 3 weekends. You could be working every 10 weekends. So, there's a lot of wide range of types of jobs out there. And, what you hear from one person does not apply to everything. So just remember that. If you really like the field, don't be dissuaded necessarily by what one person is telling you about their lifestyle. So there's different ways to approach it. All right, so we're going to jump into a case. It's a cardiology case. This is try to create to you sort of a bread and butter interventional cardiology case. The 65-year-old female with acute chest pain. All right. So 65-year-old female smoker coming in with chest pain and epigastric pain. And I'm going to try to walk you through, like, when I get involved in the situation from the point when the patient comes in, what the thought process is and how we lead from point A to point B. So 65-year-old patient coming in with chest pain and epigastric pain, right? So obviously, as you learn in med school, the most important thing is always the history, right? Before you get anything else, you're going to have just a patient in front of you. You're not going to have labs, imaging studies. So history is where all the action is at. And this is kind of what all my patients to today, I still kind of about these issues when I'm going over my history. Timing, number one, right? Ask about the timing of the pain, 3 episodes of chest pain, non-exertional, 10 minutes each, and now with ongoing pain, right? So this line already tells me my differential in my head is already listed. I already have a sense of what's going on. Asking the right pinpoint questions, boom, this gives you almost everything you need to know. Quality, epigastric, low chest burning, okay? Radiation is going to the left shoulder, and associated features, none. So this is, in a nutshell, this is what you want to extrapolate from a chest pain history. And if it's someone who's very sick, you want to be able to do that pretty quickly. And usually you can get this information in about a minute or so. Past medical history, this patient had dyslipidemia. This patient also had a significant family history. Her father had a myocardial infarction at the age of 40. And she was also a history of smoking, pack-a-day smoker for 20 years and occasional alcohol. View system is positive for fatigue and some mild weight gain, nothing pertinent really. Physical exam, blood pressure was 129/75 with a heart rate of 70 and respiration of 14. So pretty much normal looking vital signs here. In general, she was relatively non-toxic, but in mild distress. You could tell she was comfortable. She had some diaphoresis subtly on her skin. Lung exam was clear. A cardiovascular exam showed flat neck feints. There was no heart murmurs. There was no edema. There was no other signs of abnormalities. And her abdominal exam was benign. So after that, we were able to quickly get an EKG in the emergency room. So here's your EKG. All right. So I don't know how much experience y'all guys have with EKGs. If you follow my Instagram, hopefully you know a little bit. But here we'll walk through this. So this is, from my eyes, I can look at this in 1 second and tell you what's going on. A few things going on over here. Okay. We will go over some of the salient points. Let's see if I put in my little markers here. You've pointed out 2, 3, and F ST elevations. So right here, we have ST elevations in 2, 3, and F. About 2 to 3 millimeters in lead 2, about 4 to 5 millimeters in lead 3 and F. And these are sort of convex ST elevations. And what you also see here are reciprocal ST depressions in lead 1 and L. Okay. You also see some T wave abnormalities in V5 and V6. So the diagnosis here is an acute inferior ST elevation myocardial infarction. So we have our diagnosis, and if you remember the history that we had before, no big surprise here based on our history. What are our next steps? This is our diagnosis. So, well, if you're in the emergency room, you're basically going to page interventional cardiology. But before that, what are we going to do? So we have a STEMI, and if you at the moment here, when you're in clinical, all the pathophysiology, all the pharmacology, everything you probably learn is like way back in your brain, right? But, we know that an acute ST elevation myocardial infarction is caused by a plaque rupture in the coronary artery, thrombus formation. So we want to use medications that's going to attack that angry plaque that's ruptured in her right coronary, presumably, and the thrombus formation. So we're going to administer a bolus of IV heparin, right? IV heparin, which is going to target that acute fresh thrombus and help prevent propagation of that thrombus. We're going to obviously give aspirin, right? Antiplatelet therapy with aspirin. We're going to give ticagrelor, which, you can give various different, you can give clopidogrel, but these days we're giving more ticagrelor, which is a P2Y2 platelet inhibitor, because we want to get those platelets inhibited. So IV heparin is inhibiting the coagulation cascade, and ticagrelor is going to be inhibiting the platelets, right? Because no matter what we do when we go procedurally, if we don't inhibit that clot and that platelet in that plaque that's rupturing, we're not going to have a good outcome. And IV morphine, if the patient's uncomfortable, you can give that. But those first 3 medicines is what really is treating the pathophysiology of what's going on here. And of course, stat page to interventional cardiology, and hopefully I can zoom over there in time to figure out what we're going to do next. When I get there as a cardiologist, again, we're going to kind of go over again the brief history, some other things to think about in situations like this, alternative diagnosis, right? For example, an aortic dissection. There have been cases where something like an aortic dissection has presented with an acute inferior STEMI. So I always like to check pressures on both arms, always think of other things that are maybe going on. Confirm allergies, always very important. Medication, substance use, right? If this was maybe a 28 or 30-year-old person with not any medical history, you want to make sure they're not having any cocaine use, because this could impact medications and treatment. Brief physical exam, always put your stethoscope on the patient. Is there crackles? Is there any signs of congestive heart failure? Is there any heart murmur to worry about because there are mechanical complications that can occur and other bad things that someone who's having an acute heart attack can have, right? So now that we know the diagnosis is STEMI, we want to double back and make sure, okay, let's make sure there's nothing else going on here that may change what we want to do. We don't want to miss, for example, a papillary muscle rupture or an acute ventricular septal defect that would impact what we do and how we proceed. And then activate the cath lab. And that's when the fun stuff begins, right? So cath lab is where we're going to treat this patient. So the diagnosis is currently an inferior STEMI. We're presuming there's going to be an occlusion in one of our coronary arteries. So what do we do in the cath lab? Well, we use catheters, like we talked about before, to access the coronary arteries. We're going to be injecting contrast dye directly into those arteries. All right. So we snake a catheter up the arm or the leg into the coronaries. We're going to inject contrast dye to diagnose the obstruction. Once we've diagnosed that there's truly an obstruction from that plaque rupture and clot, we're going to utilize wires, balloons, and stents to open up that artery. Basically, we're doing a plumbing job on the artery, right? And it's a class 1 indication to take the patient directly to the cath lab. Now, there are some places that may not have a cath lab. If you're in some rural area or some community hospital, you can't get to a cath lab, then you're going to administer thrombolytics. Thrombolytics are basically something like TNK, which is clot busting medicine, which is going to act directly on that thrombus to try to open it up by breaking up the clot. Okay. So that's still a potentially feasible strategy in some places. So how do we get access? This is a quick little video I posted recently. I'm just going to show you how relatively quickly we can access the artery. This people, I take it for granted. People are like, how do you actually get into the heart? But basically, this is exactly how we get in there. Let's see if this has volume. Okay.
First, give some lidocaine. We then palpate the pulse and use a 21-gauge needle to get arterial access. We then insert a small microwire through the needle, remove the needle, load a sheath onto the microwire, push it through the skin and into the artery, and remove the dilator.
Okay, so once you're in, this little hole is where you can snake all our catheters and wires to get up to the heart. And from this point to actually getting our first picture of the coronary artery, I would say probably about 60 seconds. Okay, so it's quick. So once we've got our catheter up, this is the catheter I've gone up through my sheath. I've engaged it into the right coronary artery, and I take a picture. So now I'm injecting dye into the artery. And what am I seeing here? We're seeing dye travel down, but right here, we're seeing it get hung up, right? So right here is where that 100% blockage is, where that plaque rupture has caused the clot. Okay, so right at the very end, right about here. So there's a big blood clot sitting right here, and that's what's causing the problem. So now we got our catheter here, and through this tube, we're basically gonna pass a wire. So here, I'll pause this. This is our wire that we've passed through. And right here is our stent that's gone over the wire. And we're basically stenting across that blockage, okay? And afterwards, you can now see that dye that used to be hung up here is now filled completely to the artery. So we got in, we wired it, we sucked out the clot, we put the stent in, and now we've restored normal flow to the artery. And presumably the patient's ST elevations will come down, the chest pain will go away, and they're all better. So in this particular case, going from getting that sheath in to this stage, it was probably about 16 minutes. So if you know what you're doing, you can do it pretty quickly.